let's jump in. I want to kind of break this out, and you touched on it a little bit into how small cell lung cancer is treated. And I want to start with limited stage. Um, what role, and like I said, you touched on this, but what role does chemotherapy play, radiation therapy, chemoradiation, potentially surgery if that's ever an option, and what we call prophylactic cranial radiation?
Yeah, these are all different ways of treating, and basically what this comes down to, maybe let's start out with kind of the earliest. So first of all, I'll say chemotherapy is always a part of it, a part of the treatment, and I'll describe why in a moment. But if we're talking about a nodule that is found that ends up being small cell lung cancer, that's fairly uncommon, but does happen sometimes. This is To catch it that early is extremely fortunate because, as I said, this does tend to grow more quickly. Um, but if someone gets surgery and it's small cell lung cancer, even if it's an early stage one, whereas in non-small cell lung cancer that would be considered it. For small cell lung cancer, we would still give chemotherapy. And some people say, well, the surgeon told me I got it all, so why would we be doing anything else? And I say, well, that's true. The surgeon is saying that we got everything we know of. And I often will give an analogy to help with this. So looking at these scans, and I still find it absolutely amazing that we can see inside people's bodies with these scans. The technology is like Star Trek. But at the same time, it's like if we were in outer space and looking at the Earth at night, and we see New York City light up, we see San Francisco light up, we see major cities light up. But there are plenty of towns that we can't see from outer space, even though there are people there, there are lights. It's just not enough to show up. And these scans with the cancer are the same way. With small cell lung cancer, there is a higher risk that some cells flicked off from that nodule and are somewhere in the body. We can't say that they're not there. We can't see them if they are. So we give the chemotherapy to really help eliminate any cells that remain. It's not perfect, it's not guaranteed, but it does increase the likelihood of really eliminating small numbers of cells that may exist. At the time of recurrence, that chemotherapy is not something that is really curative. But after a surgery, when it's microscopic out there, it does add to the likelihood of cure, and therefore is really important. Um, no, I should say, I mean, any of these I'm discussing, this is a broad subject. So if the decision with your doctor is different, that doesn't mean it's wrong necessarily. This is where we take individuals and we make decisions together based upon what's right for that individual, not just these kind of broad categories of starting points. So if there are lymph nodes involved, especially within the middle of the chest, this is very common within small cell lung cancer. Then chemotherapy and radiation is given with a goal of cure if there are no other sites of disease that have spread. And so chemo and radiation together. Now, the radiation is generally once a day, every day, Monday through Friday for 6 weeks, or could be twice a day, Monday through Friday, for about 3 weeks as a way of giving this more condensed radiation. The chemotherapy is 4 cycles, and that's given 3 days in a row every 3 weeks, essentially. But the chemo and radiation is given together with a goal of cure. Now, extensive stage, the goal is not cure. And so, extensive stage, the treatment is to knock back the cancer. In many cases, it really, in many cases, people feel a lot better after starting the treatment, particularly if they have symptoms. So, I described earlier, patients, some people end up coming into the hospital because they're having so much shortness of breath and end up having to be put on oxygen. And I've seen multiple instances where people came in severely short of breath, needing oxygen, where we start treatment and their shortness of breath improves to the point where they actually leave the hospital off of oxygen because it has worked so rapidly. Other symptoms that can come up, which I didn't describe earlier, can be swelling in the hands or neck and face, and that's because when you get that cancer in the chest, it can pinch off the big vein that goes back to the heart from the upper body in particular, and therefore the blood is not really flowing as easily and kind of gets backed up, and that's where you get the swelling. And again, with the chemotherapy, that can resolve very rapidly as well. Yeah, so for decades, we've had the chemo regimen, carboplatin or cisplatin, these platinum agents, plus etoposide are the two drugs. And that really has been the backbone, the standard first line treatment. And really, what we also give when we're talking about chemotherapy after surgery or chemotherapy with radiation, it's those drugs as well. At an extensive stage where we're talking about controlling the disease, it's also these platinum and etoposide. I think the general impression of the public and even many physicians not working in oncology is that people believe that when someone's diagnosed with a cancer, that chemo is going to destroy their quality of life, but give them more time. And if that were true, then being an oncologist would be the most horrific job because if that were the case, you're really just making people suffer and for longer. And that is never actually the goal of the treatment. Everything is about quality of life. And many people are actually surprised that on the chemo, they don't experience nearly what they expect to experience from side effects. That's not to say there aren't any, and the treatment that I just described for small cell, people do lose their hair. Not all chemo causes people to lose their hair. For some people, that's a big deal. For some people, it's not. The amount of nausea is often dramatically less, if or sometimes none at all, from what people expect. I think people picture what it was like decades ago, and so they expect to really have nausea be an ongoing terrible problem. Now that sometimes happens. Thankfully, that's fairly rare. And most people really, if they get any nausea, it's fairly mild, and there's medicine that they take, and then it goes away, and it's mild and lasts for a couple days, if that. As I said, sometimes there are bigger issues, but for most people, that is better. Now, that chemo is given 3 days in a row, every 3 weeks. They do it 4 times and then stop. Generally, it was previously with chemotherapy, it was 4 to 6 times, and so there is a justification for cycles 5 and 6. I really was using doing cycles 5 and 6 less and less, quite frankly, because I just think the benefit in that really diminishes. Um, the only instances in which I would really more strongly consider that is someone who has no problems with the chemo treatment, and the scan after cycle 4 looks really quite a bit better than the scan after cycle 2. More recently, immunotherapy was approved. This is a few years back now. Immunotherapy was approved. Currently, FDA approved atezolizumab or durvalumab, both given with chemotherapy. We talk about the median, which is not quite the average, but we talk about the median. Now, the median isn't dramatically different when including these immunotherapy drugs, but the real benefit isn't demonstrated by the median. The real benefit is demonstrated by the number of people that really have ongoing control years out. And so we tend to look at these curves that show how many people have had recurrence or progression, sorry, the growth of their cancer. And what we see is that the group that got the immunotherapy drug, there is a higher number of patients that have ongoing years of disease control. And I have some patients that really were in. I mean, at this point, really, we're talking to really be like 5 years means they've been on one of those trials. But I do have some patients that really they are years out, and we're monitoring and doing what I call high five visits, where they're coming in and their scans look great. And now the immunotherapy, when it works, is absolutely revolutionary. It is a home run drug. And really, I think where the biggest research need is is in the group of patients that don't get the benefit, or better identifying who's really going to benefit from the immunotherapy and who is not, and finding better options for that group. We will not stop working at this until everyone has that home run, until all patients are cured. And there's a lot going on toward that, and there continues to be a lot of need for that, but we are getting some real wins in small cell lung cancer, which for decades has been really challenging. Non-small cell lung cancer, the last decade, this has become a totally new field in the last decade. Many of the drugs we're using in non-small cell lung cancer are new in the last 5 to 10 years. Small cell lung cancer, I think we're just starting to get these wins.